Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today, we will be discussing on some concepts on acute kidney injury. Acute kidney injury, as we know, is an abrupt decrease in kidney function, resulting in the retention of urea and other nitrogenous base products and dysregulation of extracellular volume and electrolytes. Abrupt means it is usually less than 7 days duration. There is sustained decrease in the renal function. Sustained means more than 6 hours at least. The term AKI has replaced acute renal failure. The importance is the smaller decrements in renal function occurs before the renal failure. So that is why the term acute kidney injury has replaced acute renal failure. So now we look into Critico defines AKI as one of the following. So mainly look at the serum creatinine and urine output. So increase in serum creatinine by 0.3 milligrams within 48 hours. That is, it is acute in onset. Or increase in serum creatinine to 1.5 times baseline within 7 days. That is why initially I said kidney injury, the acute means within 7 days. So if somebody's serum creatinine was 1 milligram, if it has increased to 1.5 milligram, it means the patient has got acute kidney injury by the second definition. And if it has become 1.3 in 48 hours, it is again acute kidney injury. More sensitive one is the urine output. Less than 0.5 ml per kilogram per hour for 6 hours. Is a patient is 60 kilograms, 60 into 0.5 is equal to 30 ml per hour into 6 hours. That is, in 6 hours there is less than 180 ml output. This patient has got acute kidney injury. Hope this definition is clear to you. So acute kidney injury by the Critico criteria has got two components. One is by looking into serum creatinine and second is by looking into the urine output. So now there are different stages for AKI. So we look into how the AKI is staged according to Critico criteria. 3 levels based on serum creatinine, and so here again the serum creatinine and urine output are the criteria. Stage 1, serum creatinine more than 1.5 to 1.9, that is less than 2 times baseline, or more than 0.3 milligram deciliter increase. That is stage 1. So somebody has got a 1 milligram creatinine initially within the presumed to be there during the last 7 days, and if it has become 1.5, patient has developed a grade stage 1 acute kidney disease. Next is the urine output 0.5 ml per kilogram per hour for 6 to 12 hours. So during the last 12 hours, 6 to 12 hours, the urine output is less than 0.5 ml per kilogram. So the patient is 60 kilogram. So we have already calculated for 1 hour it should be 30 ml 12 hours. So during 6 to 12 hours the output is less than this stage 1. Stage 2 serum creatinine is between 2 to 3 times the baseline. So 1 milligram has become 2.9. Up to that, we can say the patient has developed a stage 2. So urine output is again same 0.5 ml per kilogram per hour for more than 12 hours. So 30 ml per 60 kg for more than 12 hours. Stage 3 is simple to remember. Serum creatinine is more than 3 times the baseline. So the baseline was 1 milligram. If it becomes 3 or more more than 4 milligram rise. So suppose it is 1 and it has become 4 milligram, we can say stage 3. Urine output is little different. It is 0.3 ml per kilogram per hour for 24 hours or anuria for 12 hours. So anuria for 12 hours or 0.3 ml per kilogram per hour for more than 24 hours. This patient has got a acute kidney injury. So this is how you classify or stage the acute kidney injury into stage 1, stage 2 and stage 3. Very simple to remember. Stage 1 is 1 to 1.9. So that is less than 2 times. 2 is less than 3 times the baseline creatinine, and stage 3 more than 3. The output, the stage 3 is important. Remember the anuria more than 12 hours or urine output less than 0.3 ml per kilogram per hour into more than 24 hours. So why we are taking urine output even when we are checking the serum creatinine? Urine output is a critical parameter in the diagnosis of AKI. This is because there is a lag. So here you can see that the patient has got a reduction in the glomerular filtration rate. The serum creatinine rises sometime later. So even before the serum creatinine comes down, or increase, not comes down, even before it increases, the GFR has decreased, and you can say that the patient has gone into the renal function has decreased. That is why urine output is given a very significant level of importance in the parameter for diagnosing AKI. Hope this is clear. So urine output is a more sensitive indicator than serum creatinine acute kidney injury. Now why are you taking the baseline creatinine in the AKI diagnosis? Baseline creatinine reflects the patient's normal kidney function, so that you will not make a diagnosis of chronic kidney disease as AKI. So beyond the concept to be remembered is that the diagnosis of AKI is based on rise in serum creatinine from the baseline. So now we look into how does KDIGO classify AKI based on the etiology. Classically, we divide the kidney disease, acute kidney injury, into 3 main types depending upon whether it has occurred before the kidney, that is it is pre-renal, renal and post-renal. So this is a fundamental classification. Pre-renal is due to decreased renal perfusion. Example, somebody has got vomiting, diarrhea, hypotension, heart failure, sepsis. All these lead to renal artery stenosis. All this can lead on to pre-renal AKI. Another example is cirrhosis. Intrinsic kidney disease is due to injury to the tubules, like acute tubular necrosis or glomerular nephritis. Tubular necrosis can occur following a pre-renal. Pre-renal can produce hypertension, it can produce a tubular injury, so acute tubular necrosis can occur. So pre-renal disease can lead on to intrinsic kidney disease. The difference between these will be discussed at a later stage. Post-renal is due to obstruction of the urine flow. Example, in a male, think about the benign prostatic hypertrophy, renal stones. Identifying the type is crucial for targeted disease, targeted treatment. So fundamentally, when a patient comes with renal failure, exclude pre-renal, exclude post-renal, then think about the renal causes. Hope it is clear to you. Early recognition of AKI is very important because it prevents progression to chronic disease. A few percentage of AKI can lead on to. Second, it reduces the mortality and morbidity. It enables early intervention such as fluid resuscitation, avoiding neurotoxic drugs, and optimizing the hemodynamics. So, newer methods of biomarkers is being investigated. We come to that. So the point to be remembered is that the kidney disease, this is the normal kidney. There are persons who have got increased risk of renal injury, and the patient develops damage to the kidney. This leads on to decreased glomerular filtration, and finally the kidney fails. So this acute kidney injury goes through a spectrum. Initial part, you have to assess the risk. You have to recognize the injury and the damage and decrease in renal perfusion or the glomerular filtration. You have to do the response, and if the kidney fails, you go for renal support. So remember that acute kidney injury goes through a spectrum, and as mentioned, the early recognition is very important. The traditional biomarkers or markers are serum creatinine, the glomerular filtration rate, and urine output. This is what we use in the diagnosis. That is serum creatinine, glomerular filtration, and the output. Again, acute kidney injury, GFR or estimated GFR is not given much importance except in children, where L is less than 35 ml is taken as acute kidney injury. So these are the traditional things. Then the damage biomarkers which are being investigated, one is the NGAL, second is the KIM1. These are under investigation. Glomerular filtration biomarkers are cystatin C, alpha-1 microglobulin, beta-2 microglobulin, microalbumin, and proteinuria. Other inflammatory biomarkers are also there, interleukin 18, and different emerging biomarkers which are beyond the scope of today's discussion. So point to be remembered is that it is very important to diagnose the acute kidney injury, and we should think about the newer biomarkers. How will you manage acute kidney injury? Management is based on identifying and treating the underlying cause, whether it's a pre-renal, renal, or post-renal, optimizing the hemodynamics, maintain euvolemia, mean arterial pressure should be more than 65 ml, 65 millimeters, avoiding nephrotoxic drugs, NSAIDs, aminoglycosides. These are very important. So this is the way in which you go for management. Of course, correction of the height, the electrolytes, fluid management, monitoring the potassium, sodium, and bicarbonate. And when the patient develops renal failure, you go for renal replacement. The indications for renal replacement are severe AKI, that is stage 3 AKI with volume overload, acidosis, hyperkalemia, or symptomatic uremia. From center to center, the indications for and the criteria for taking the patient for renal replacement therapy varies, but these are the main guidelines. You can say the stage 3 disease with the evidence of fluid overload, acidosis, hyperkalemia, or symptomatic uremia. Now, we have said that kidney disease has got risk factors. Risk factors can be patient related or environmental. Patient related are age is the most important thing. Diabetes mellitus, hypertension, CKD, heart failure, cirrhosis. Second is the hospital related factors. Patient has got sepsis, dehydration, hypotension. Nephrotoxic drugs, very important. NSAIDs, aminoglycosides, and contrast media. Major surgery, cardiac procedures. Preventing AKI in high-risk patients involves hydration, drug modification, and close monitoring. Now, what are the AKI has got significant morbidity and mortality. 1% of AKI is due to community-acquired problems. In the ICU settings, this can vary up to 25%. 5 to 25% of the people can develop AKI. And AKI with the renal replacement, the mortality is very high, especially when there is multi-organ dysfunction. Up to 80% can occur with multi-organ dysfunction. So AKI has got a lot of complications, mortality and morbidity. So AKI can lead on to electrolyte disturbance, especially hyperkalemia and acidosis. The most important thing to be kept in mind. Second is volume overload leading on to pulmonary edema, hypertension. And third is uremic complications like encephalopathy and pericarditis. Progression to CKD, increased risk of kidney injury going on to CKD if the recovery is incomplete. And as already mentioned, AKI is linked with ICU admission and poor outcomes, and early intervention can reduce the complications. A few words on how to differentiate AKI from CKD. And many times CKD patients goes into AKI. It is called acute on chronic kidney disease. And let us look into what are the major differences between AKI and CKD. Onset is sudden, we have already mentioned, hours to days, 6 hours to 7 days. Here the chronic kidney disease, it should be the more than 3 months. A new term has come, acute kidney disease, in order to fill the gap between the duration of the time between the, because AKI is 7 days and CKD is more than 3 months. So many times it is used acute kidney disease. Acute kidney disease is reversible usually. CKD is irreversible, it is a progressive disease. And the critical criteria here is creatinine and urine output, but in CKD it is eGFR less than 60 ml per minute per 1.73 meter square for more than 3 months, or if the eGFR is more than 60, we take imaging for renal functions like your proteinuria as an evidence for kidney disease. The causes are different. Sepsis, nephrotoxins, and hypovolemia are the pre-renal causes, very important. And CKD, it is diabetes, hypertension, glomerulonephritis. Management, acute is mainly supportive and renal replacement as a temporary measure. And CKD, the management is a progressive disease, manage the comorbidities, slowly progressive. So today we have discussed about the few concepts in acute kidney injury and the difference between AKD, acute kidney injury, and the CKD. We have said about the stages of AKI and the major complications. Stay tuned for further videos. Thank you.